Hi everyone. Can you please tell me if I am audible, visible both? Hi. Can someone tell me if I am audible, visible? Please write in your chat box. Is everything okay? Can we begin? Yes, Jai Mohan Jangir, thank you so much for the confirmation. So basically today we are going to have a recall session. And this recall session will be for the FMGE students who have recently, who will be later appearing for their exams. And the examination just happened a few days back. So this is a recall session. Okay. Now, let me tell you about something very exciting that an academy has come up with, and that is NEET PG Vitals. Okay, so these are recorded videos which are meant for comprehensive NEET PG preparation. So these are, of course, live classes and batches will continue. Okay, but these are recorded videos. So these have 800 plus hours of recorded classes by the top educators across 19 subjects. They have clinical PYQs and MCQ sessions, flowcharts, images, tables are included for better retention, and practice questions are available at the end of each topic. Okay, so basically, there are three kinds of packages. One is NEET PG Live, where you get access to the live batches. Then you have NEET PG Vitals, where you have access to the recorded content. And then you have a combo package where you have access to both the live and the recorded content. Okay, so the subscription for the NEET PG Vitals is currently at a price of 13,500. The original price is 30,000. So I think this is a very, very good opportunity for you to, invest in this. And I think it is going to give you very great returns. Apart from that, from today, there is this last leap marathon for NEET PG 2023, and there will be 102 hours of dedicated rapid revision by all the educators of an academy, and all 19 subjects will be covered for holistic preparation. So most expected topics along with the high yield practice sessions will be included, and that will include test and discussion, IBQs, PYQs, and this will be with the NEET PG live subscription. So you can get 2 months of NEET PG live subscription at a subsidized cost of 6,999 only. Okay, so please remember, when you do subscribe to this, please use the code mentor, mentor. Mentor is the code to subscribe to this particular package. Also, to tell you, there was supposed to be an exam at 9 a.m. I hope you people have enrolled for it and you have attempted the examination, because this is a free test for all the medical aspirants, and you will get a 100% scholarship if you do well in this. To tell you about these NEET PG combo, which I told you is a combination of both live subscriptions as well as vitals. So this is 1 year and above subscription. The costs have been subsidized as mentioned in this table. So you will be saving a lot of money if you do subscribe to it right now, and do subscribe to it and use the code mentor when you subscribe. Okay, this offer is valid only till Jan 31st. Okay, so please hurry. Now let's go on to the questions. So we have approximately around 55 minutes. I will be discussing obviously what is mentioned and what came up in the examinations. Of course, we'll be discussing the related theory as well. If you have any extra questions, if you want me to discuss something specific, please feel free to mention in the chat box. If you have any doubts, if you have not understood anything, if you want me to repeat something, also please mention it on the chat box. Okay? All ready? Please give me a thumbs up. I should be aware that people are listening to me. Otherwise, I need a feedback. All okay? So let's begin with the dermatology FMGE recall questions. The first question. A patient presented with multiple painful blisters on an erythematous base along a dermatome on the trunk as shown in the image. What do you think is the answer for this question? Is it herpes simplex, herpes zoster, molluscum contagiosum or chickenpox? Anyone? Please write it. Please write your answer in the chat box. Yes, so Surya mentions it's B. Anyone else? Yes, Jai Mohan also says it's B. It's a very simple question. You can see that the patient is presenting with painful blisters. Painful blisters. And they are present on an erythematous base. And they have also mentioned that it is present along a dermatome. So in this question, even if they had not given you the classical picture, from the description, it is very, very, very evident. The answer, yes, Surya and Jai Mohan, you are right. The correct answer is herpes zoster. So sports life, I will tell you why it is not molluscum and why it is not chickenpox. So basically, remember that whenever you see grouped vesicular lesions which are associated with pain, associated with burning sensation, and when they are present along a dermatomal distribution, it is nothing but herpes zoster. Okay, so herpes zoster is caused by the varicella zoster virus. It is the same virus which causes varicella, right? Varicella is nothing but chicken pox. Okay, so what happens is when one gets varicella, the virus remains latent into the body. Okay, and then whenever the immunity of the body is a little on the lower end, this virus can get reactivated, and when it gets reactivated, it travels along a nerve. So when it travels along a nerve, it gives rise to these multiple grouped blisters or vesicles. Vesicles are nothing but fluid-filled lesions. These fluid-filled vesicles, they are having a central umbilication in most cases, and they are present over an erythematous base. Now the patient in a case of herpes zoster can have pre-herpetic neuralgia, means the patient will complain of intense pain, burning sensation along that particular dermatome before the appearance of the vesicles. There can be pain associated with the cutaneous lesions of herpes zoster, and there can be even post-herpetic neuralgia, means even after the skin lesions completely resolve, the pain and burning sensation or the different kind of sensations that one can experience in post-herpetic neuralgia, they tend to remain or they appear around 120 days after the appearance of herpes zoster, right? So please remember, why is it not herpes simplex? Now herpes simplex is caused by the herpes simplex virus. Herpes simplex virus are of two types, herpes simplex 1 and herpes simplex 2. Herpes simplex 1 causes herpes labialis, or it causes herpes, it is also called as herpes labialis, herpes orolabialis. Okay, so herpes labialis is most often caused by HSV1, and HSV2 causes herpes genitalis. Okay, now here in herpes you are going to see multiple vesicles which are grouped together, but the lesions will not be in a dermatomal fashion. So if you're talking about herpes orolabialis, the lesions will be somewhere around the mouth. They may be on the lips, they may be inside the mouth as well. Sometimes they may be clustered onto the perinasal area, sometimes in the periocular area as well. Okay, but they will not be in a dermatomal fashion. Okay, so that is HSV, herpes labialis, most commonly caused by HSV1. Going on to herpes genitalis. Herpes genitalis is the most common sexually transmitted disease in the world. Herpes genitalis is caused most often by herpes simplex virus 2. The lesions, they can be present in a grouped, they present as grouped vesicular lesions. Okay, they may be present over an erythematous base, and these vesicles, they may rupture to form erosions, and these erosions, they typically have polycyclic borders, Okay, now please remember that latency is a feature of both HSV1, HSV2 as well as VZV. So, as I mentioned that the VZV virus remains latent in the body and then gets reactivated to cause herpes zoster, the same fashion HSV virus also remains latent into the body. So, there can be reactivations of herpes labialis as well as herpes genitalis. Okay, so the first exposure to the HSV virus causes the primary episode of herpes, and the subsequent episodes which happen because of reactivation are called as secondary episodes. Okay, now as the age advances, as the time progresses, the recurrences of herpes labialis or herpes genitalis, they tend to become lesser, and the symptomatology, like say when the patient has the primary episode of herpes labialis, there is a lot of blistering, there is a lot of pain, there is a lot of swelling. Okay, while in herpes genitalis, especially in the females, in herpes genitalis the pain may be severe enough to cause urinary retention. Okay, now this symptomatology decreases as the remission, I mean, as the relapses occur over a period of time. So each relapse is a milder than as compared to the previous relapse. Okay, the duration of the viral shedding that also declines with each episode of herpes labialis or herpes genitalis. Right, now let's see a few images of these problems so that you have a better clarity on the subject. So now this herpes simplex virus, as I mentioned, it remains latent in the, where does it remain latent? See, this is again a very important MCQ. It remains latent in the sensory ganglia after the primary episode. Primary episode means the first exposure to the virus, from where it periodically reactivates. So how does the HSV virus cause appearance of blisters or appearance of vesicles? Okay, now remember that this HSV virus, it goes into the keratinocyte. Okay, and when it goes into the keratinocyte, what happens is the keratinocyte changes shape. The keratinocyte was polygonal in shape earlier and now it becomes rounded. It becomes ballooned up. Right, so that is called as ballooning degeneration. This is very, very important for you to remember from the MCQ point of view. So please pay attention. Everyone with me, please give me a thumbs up. Please keep this chat box active. I should know that you are listening to me. Okay. So basically HSV, yeah. So basically remember that this particular virus, when it enters into the keratinocyte, this virus causes this kind of ballooning of the keratinocyte. So these are all balloon cells. As you can see, these are all balloon cells. Now what happens is the adjacent keratinocytes, they fuse and they appear large and multinucleate. So what happened is these balloon cells, they came together. Okay, the cell wall in between the keratinocytes is lost and it becomes one whole large cell with multiple nuclei within it. So this is called as the multinucleated giant cell. Okay, so please remember, on histopathology of herpes simplex or herpes zoster, you are going to see the presence of multinucleated giant cells. So when the balloon cells rupture and the cells fuse and give rise to a multinucleated giant cell, that is called as reticular degeneration. Okay, so please remember, in HSV you are going to see ballooning degeneration as well as reticular degeneration. So what is the clinical implication of this? Like suppose if you are suspecting herpes zoster or herpes simplex and you want to do a bedside test to diagnose these conditions, then what you can do is you can do a simple procedure which is called as the Zank smear. So what is a Zank smear? Suppose if there is a vesicle, you just deroof the vesicle, okay, remove all the fluid from the vesicle, scrape the base of the vesicle, and then you place it on a clean glass slide. And when you see on the clean glass slide, you will be able to see the presence of multiple multinucleated giant cells. Okay, so that will give you the diagnosis with that you are dealing with herpes group of infections. Okay, so this is what a primary episode of herpes labialis would look like. So here you can see there are multiple vesicles, right? There, as you can see, there are multiple vesicles. Vesicles are, as you can see, clear fluid filled blisters. Okay, so these vesicles, they are present over an erythematous base. Okay, you can see it is present here. You can see it's quite an extensive involvement. It is also present in the perinasal area, right? So there are multiple vesicles which are grouped together on an erythematous base. The patient has associated pain and burning sensation. Okay, so the initial episodes are usually severe and painful. Recurrences can be triggered by fever. So that is why they are also called as fever blisters. And the lesions, they tend to become milder and milder as the time progresses. So how do you treat orolabial herpes? The way you treat it is with acyclovir, famciclovir or valacyclovir, which are given during the clinical episodes. Acyclovir, famciclovir, valacyclovir, they are all antivirals. Okay. So basically the way they work is that they inhibit the viral thymidine kinase. Okay. And that's how it decreases the replication of the virus, and that's how it helps in the active stage of the disease. Now you have to remember this as we were discussing HSV. You have to remember this is a very, very, very important question and important MCQ. What is Kaposi's varicella eruption? The other name for Kaposi's varicella eruption is eczema herpeticum. Okay. Kaposi's varicella eruption is a severe disseminated form of HSV1. So there it is a disseminated version of HSV1. And when will this happen? Now suppose if the patient is having some condition which is impairing the barrier function of the skin. So what is impairment of the barrier? See, normally barrier means whatever is inside will remain inside and whatever is outside will not go inside. Right? That is the normal barrier function. Now, when you have an impairment of the barrier function, the water which was supposed to remain inside the skin goes out into the environment, and the things which are outside, which can be viruses, they can have an easy access into the skin. So, impairment of barrier function can happen in a multiple of diseases. So, the most common is atopic dermatitis. Okay, so in atopic dermatitis, the primary problem is the impairment of the barrier, right? So, atopic dermatitis, Darier's disease, Haley-Haley disease, pemphigus foliaceus, these are causes where there can be a high possibility of eczema herpeticum because of the impairment of the barrier. Okay. So what happens is this virus HSV1 gets easy access into the skin and then it can disseminate very easily. Okay. So there will be multiple vesicular lesions and these vesicles will be disseminated and there can be associated involvement of the organs. There can be associated involvement of the brain. There can be involvement of the liver. There can be involvement of the lungs, right? So the treatment is always intravenous acyclovir because these patients are also likely to be immunosuppressed, right? So remember that severe disseminated HSV1 infection is called as Kaposi's varicella eruption, also called as eczema herpeticum. Please remember the conditions in which you can see this problem. Okay, like atopic dermatitis, Darier's disease, Haley-Haley disease, and pemphigus foliaceus. Now, another presentation of herpetic infection is herpetic whitlow. Now, this is an entity which you should know. The reason being that herpetic whitlow means there is swelling of the finger, okay, and the nail fold, periungual area. Basically, when you have involvement of the periungual area, periungual means around the nail, okay. So when you have accidental inoculation of the herpes simplex virus on the finger, okay, accidental inoculation of HSV1 on the finger, how can it happen? It can happen in healthcare workers. Okay, so if you are handling a patient having HSV1, if you are touching the lesions with your bare hands, okay, then it can get inoculated onto your finger. and in the periungual area, and that will give rise to a painful swelling. So that is something that you see in healthcare workers, that is called as herpetic whitlow. Now, a very important question, and that is genital herpes. This is something that you have to remember. Everything about genital herpes should be pit pat. This is because one, it is the most common STD in the world, and STD forms a very important part of your curriculum, and multiple questions have come on STDs in the past. You should know everything about genital herpes, so please pay attention. Now see, this is a very important flow chart which will help you to diagnose the STD ulcers very easily. Okay, so when you have a patient who is coming to you with an STD ulcer, first ask the patient, is the ulcer painless or is the ulcer painful? Okay, now next thing that you're going to do is to look at the lymph nodes. Look at the lymph nodes. Are the inguinal lymph nodes painless, or there are painful, or there are no inguinal lymph nodes? Okay, so then you decide if the ulcer is painless and the inguinal lymph nodes are also painless, then what you are dealing with is primary chancre. Where do you get primary chancre? Anyone can write it in the chat box. Where do you get primary chancre? In which condition do you see primary chancre? Which STD? Surya, Zaid, anyone? Jagmohan, anyone? In which condition do you get the primary chancre? No reply. The correct answer is syphilis. Okay, primary stage of syphilis is called as primary chancre. So when you have a painless lymph node with a painless ulcer, okay, you have primary chancre will be your diagnosis. Okay. Now, when you have a painless ulcer with a painful lymph node, okay. Now remember that is seen in lymphogranuloma venerum. What is the causative organism of lymphogranuloma venerum? Sandesh Shirsagar, please answer. What is the organism causing lymphogranuloma venerum? Anyone? Anyone? No. Not CMV. So remember, lymphogranuloma venerum is caused by chlamydia trachomatis. Okay. It is caused by chlamydia trachomatis, and it is caused by serovars L1, L2, L3. Very good, Mahesh Narayan Mishra. Can you please tell me what is the causative organism of syphilis? What is the causative organism of syphilis? Yes, very good. Treponema pallidum. So, Treponema pallidum is the causative organism of syphilis. It's a spirochetal organism, right? Okay. Now, when you have the ulcer painless as well as lymph node is absent, okay, you do not see the lymph node or you do not feel the lymph node, then your diagnosis will be donovanosis. So remember, in donovanosis, you do not have a lymph node swelling, but you will have a granulomatous swelling at the site of the lymph node. Okay, so it is a granulomatous swelling which is present at the site of the lymph node. Okay, so this granulomatous swelling which is present at the site of lymph node is called as a pseudobubo. So remember, pseudobubos are seen in donovanosis, and as Mahesh Narayan Mishra has correctly mentioned, donovanosis is caused by Klebsiella granulomatis. Okay, it is caused by Klebsiella granulomatis. Okay, Now the other name is Calimatobacterium. Okay, Calimatobacterium granulomatis. Okay, now please remember donovenosis. The other name for donovenosis is also granuloma inguinale. Granuloma inguinale. Okay, granuloma inguinale. Why? Because it is a granulomatous swelling at the site of the lymph node, and that is called as a pseudobugo. So the other name for donovenosis is granuloma inguinale. Okay, now if you have a painful ulcer with a painless inguinal lymph node, then your diagnosis will be herpes genitalis. Herpes genitalis is caused by herpes simplex virus 2. Correct? So remember, painless lymph nodes with painful ulcers are seen in herpes genitalis. Now, if you have a painful ulcer and a painful lymph node, then what is the diagnosis? It is chancroid. What is chancroid caused by? Anyone? What is chancroid caused by? What is the causative organism of chancroid? Aziz, it is not psoriasis. Psoriasis is a completely different condition. Yes, very good, Mahesh. It is, yes, it is Haemophilus ducrei. Very good, Aziz. Very good, Lokesh. Yes, it is Haemophilus ducrei. So, remember, chancroid is like a cry for help because everything is painful. The ulcer is also painful and the lymph node is also painful. Right? Yes, very good, Sandesh. It is Haemophilus ducrei. Right? So now you have to remember that the ulcer in primary chancre is painless. The lymph nodes are also painless. The characteristic feature of the lymph nodes in primary chancre is that they have a shorty or they have a rubbery feel. Okay, and consistency is firm. Okay, they are indurated. And if you see the primary chancre is also having an indurated base. And that is why it is also called as the hard chancre. It is a clean looking solitary ulcer with an indurated base. Okay, then chancroid is, on the other hand, is a soft chancre. Okay, because it has a non-indurated base and it is a dirty looking ulcer which can be multiple as well. Okay, so this is something very, very important. Yes, Aziz, I know that there was a psoriasis question. Thank you so much. We will be discussing that as well. Okay, now if you have a question in which they say that there are recurrent genital ulcerations, but if they have specifically mentioned that it heals with hyperpigmentation, okay, if it is healing with hyperpigmentation, your answer will be it's a fixed drug eruption. If they tell you it does not heal with hyperpigmentation, then your diagnosis is genital herpes. So this is something that you need to remember. If a question comes with recurrent genital ulcerations, okay, then please remember, if they are healing with hyperpigmentation, your answer will be fixed drug eruption. Okay, so this is what herpes genitalis looks like. I told you it's caused by HSV2 more commonly than HSV1. The incubation period is 5 days. It is a sexually transmitted disease, and the disease can occur not only in when you have active episode of herpes, but can also happen in between the episodes when there is asymptomatic viral shedding. So, as with any herpes disorder, the initial episodes are always severe and recurrences are the norm, but they are less painful than the earlier episodes. Inguinal lymphadenopathy is bilateral and painless, and chronic ulcerative lesions with no tendency to heal are seen in acquired immunodeficiency syndrome, that is AIDS. Now, how do you approach a patient who is coming to you with recurrent episodes of herpes genitalis, more than 6 to 12 episodes per year? Okay, in that case, you need to give a continuous antiviral prophylaxis. The reason, it reduces the asymptomatic shedding. Okay, so Recurrent herpes genitalis, more than 6 episodes a year, please think of giving suppressive therapy with acyclovir. Now there is an entity which is called as acyclovir resistant herpes genitalis. Okay. Now for such cases you can give foscarnet or cidofovir. Remember this. This is again a very important question. What is the treatment for acyclovir resistant herpes? It is foscarnet or acyclovir, cidofovir. Okay. The option 3 was varicella. Now this is what varicella looks like. Varicella is nothing but chicken pox. It is caused by the varicella zoster virus, and the typical presentation starts with fever, and after 1 to 2 days of fever there are papules. These papules, they soon turn into vesicles, and these vesicles, they have a typical erythematous base to it, and that gives rise to the typical appearance. What is the typical appearance of varicella? Dew drop on a rose petal. Okay, so dew drop on a rose petal appearance is classically seen. These vesicles, they turn into pustules and then they can crust. Polymorphous lesions are seen. This is very, very important for you to remember. What is polymorphous means? The lesions are in different stages of evolution. So here you can see it is just beginning, like an erythematous papule. Here it is forming a vesicle. Here it is forming a vesicle with central umbilication, and somewhere it will form a scab. Okay, so you see lesions which are in different stages of evolution. Okay, so that is why it is called as polymorphous lesions. It has a centripetal distribution. Centripetal means maximum concentration of the lesions is in the center. Okay, the lesions towards the periphery, they become lesser. On the acral areas, they tend to become lesser. And when is the patient not contagious? When all the scabs, the crusts, when they fall off, the patient becomes not contagious. Okay. Now this is something very, 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 very important, and you all should remember this. You should know how to approach varicella in a pregnant patient. See, understand, if a patient gets an infection within the 20 weeks of gestation, okay, within 20 weeks of gestation, then there is a 2% risk of fetal damage, and that is called as congenital varicella, which can present with limb hypoplasia, cutaneous scars, ocular and neurological defects. Treatment is oral acyclovir. Okay, so if infection is occurring within 20 weeks, 2% risk of fetal damage, which is called as congenital varicella. Okay, so in congenital varicella, there will be limb hypoplasia, cutaneous scars. Okay, then if there is a perinatal infection, which is 5 days before and 2 days after delivery, then what can happen is that this virus, the baby is immunologically unprotected, right? Because the mother did not have the time to produce the antibodies and pass it on to the baby. Okay, so that is why in perinatal infection, which happens 5 days before and 2 days after delivery, it is important that one should give prophylactic acyclovir in such patients who have had history of herpes genitalis, because if there is a perinatal infection, it can cause severe neonatal varicella, and the mortality of severe neonatal varicella is up to 30%, right? So it is very, very important that when you want to prevent perinatal infection, because if a patient is already having a history of herpes genitalis, it is likely that it can get reactivated, okay, in the last few days of pregnancy. So that is why you should give prophylactic acyclovir in such patients. But if you have missed giving that, then there is a chance of perinatal infection, and in that case the neonate will be immunologically unprotected, and neonatal varicella has a high mortality. So what do you do if there is an infection now? In such a case, you give varicella zoster immunoglobulin to the baby, because you want the baby to have antibodies to fight off the virus, and you give IV acyclovir therapy to the mother. Now suppose if the mother has been exposed to a varicella case, okay, but patient does not have varicella, but she is exposed to a varicella case, then VZIG alone should be given to the mother within 72 to 96 hours of exposure to prevent maternal varicella. Okay, so what do? You give the mother varicella zoster immunoglobulin so that maternal varicella can be avoided. Okay, now this is the question that we were talking about, and this is nothing but herpes zoster. Look at the typical blisters, look at the erythematous base, see the clustering and see the dermatomal distribution. Now, remember the signs associated with herpes zoster. The first is the Hutchinson sign. So, if you see vesicles are seen on the side of the nose in the ophthalmic zoster, then the eye is usually affected. Okay, so if you see that there are vesicles on the side of the nose or on the tip of the nose, that is suggesting that you have involvement of the nasociliary nerve. Okay, and that can give rise to blistering. Okay, and that is suggesting that there can be impending involvement of the eye, and that is why you should refer the patient to the ophthalmologist. Right, another complication of herpes zoster is Ramsay-Hunt syndrome. So in Ramsay-Hunt syndrome you have vesicles which are present inside the external auditory meatus. There can be vesicles on the tympanic membrane as well, and this happens because of the reactivation of the virus in the geniculate ganglion. Okay, and that can give rise to Ramsay-Hunt syndrome. So it is a triad of facial palsy with otalgia and external auditory meatus showing vesicles. Okay, so basically if you see herpes zoster or oticus with facial palsy, you should think of Ramsay-Hunt syndrome. Okay, so Maxtan tells me that I should also talk in Hindi. ठीक है, no problem. So basically molluscum contagiosum was one of the options. तो इस कंडीशन में क्या होता है, बेसिकली प्लीज रिमेंबर कि ये एक प्रकार का वायरल इन्फेक्शन है. मोलस्कम कंटेजियोसम होता है एक वायरस से जिसका नाम है पॉक्स वायरस. ओके, तो उसमें दो टाइप के वायरस होते हैं, टाइप 1 पॉक्स वायरस और टाइप 2 मोलस्कम कंटेजियोसम वायरस. तो मोस्ट कॉमनली ये ज्यादातर टाइप 1 मोलस्कम कंटेजियोसम वायरस से होता है. एंड ये जो टिपिकल डिस्क्रिप्शन है ये आपको याद रखना बहुत जरूरी है. ओके, सो यू विल सी दैट देयर विल बी शाइनी पर्ली वाइट umbilicated papules are classically seen. Okay, तो दिस डिस्क्रिप्शन ऑफ पर्ली वाइट umbilicated का मतलब कि बीच में डिप्रेशन होता है, राइट? Okay, so this is an umbilicated papule. So when you see shiny pearly white umbilicated papules, it is suggestive of molluscum contagiosum. अभी अगर आप ये मोलस्कम कंटेजियसम बॉडी निकालोगे, ये जो लीजन है इसका मैं अगर टॉप निकाल दूँ और उसके अंदर का जो बॉडी मैं अगर एक ग्लास स्लाइड पे देखती हूँ, देन व्हाट विल आई फाइंड? तो उसमें इन्फेक्टेड केराटिनोसाइट्स में बॉडीज दिखेंगे. वो बॉडीज को मोलस्कम बॉडीज कहते हैं या फिर हिंडरसन पेटरसन बॉडीज कहते हैं. ठीक है, सो दिस डिसमिनेटेड मोलस्कम कैन हैपन इन द सेटिंग ऑफ HIV. HIV में प्रतिकार शक्ति कम हो जाती है, उसके कारण ये वायरस बहुत ज़्यादा फैल जाता है. ओके, इसलिए अगर आप बहुत सारे ऐसे डिसमिनेटेड मीन्स अलग अलग जगह पे बहुत सारे वायरसेस अगर आपको दिखते हैं तो आपको HIV का टेस्ट करवाना चाहिए. सो डिसमिनेटेड मोलस्कम इज सीन इन HIV. प्लीज रिमेंबर दैट व्हेन यू सी molluscum like lesions, okay, molluscum like lesions means lesions which have a central umbilication. ऐसे lesions जो molluscum जैसे दिखते हैं वो आपको क्रिप्टोकोकोसिस, हिस्टोप्लाज्मोसिस और पेनिसिलियोसिस में भी मिलेंगे. ओके, सो अगर molluscoid lesions है HIV के सेटिंग में तो आपके डिफरेंशियल डायग्नोसिस क्या है? एक क्रिप्टोकोकोसिस, दूसरा molluscum contagiosum itself, तीसरा हिस्टोप्लाज्मोसिस और पेनिसिलियोसिस. ठीक है, नाउ molluscum contagiosum exhibits pseudokeibnerization. pseudokeibner का मतलब ये होता है कि अगर molluscum contagiosum का वायरस एक जगह पे है और आपने वो एरिया को खुजा दिया तो वो वायरस वो जो आपने जिस एरिया में ट्रॉमेटाइज किया है वो एरिया में भी वो चला जाता है, ऑटो इनोक्यूलेशन हो जाता है, जिसके कारण you will see that there will be a linear presentation. So this is called as pseudokeibnerization. Pseudokeibnerization is something that you will see in warts as well as in molluscum contagiosum. Okay, संदेश ट्रॉमा में भी होता है बट दैट इज ट्रू कीबनराइजेशन. ओके, ये हम सूडो कीबनर की बात कर रहे हैं. ट्रॉमा कोई भी प्रकार का हो, मैकेनिकल ट्रॉमा, थर्मल ट्रॉमा, केमिकल ट्रॉमा, तो उसमें जो लीजन आते हैं जो प्राइमरी डिसीज वहां पे जो आ जाती है उसे ट्रू कीपनराइजेशन कहते हैं. एंड ट्रू कीपनराइजेशन इज समथिंग दैट यू सी इन सोरासिस, लाइकन प्लेनस एंड इन विटलाइगो. ठीक है. नाउ लेट्स गो टू द नेक्स्ट क्वेश्चन. 3 month old child presents to the hospital with a bright red birthmark as shown in the image. What will be the diagnosis? Anyone can tell me the answer? What is the answer here, please? देखो, हर्पीज जोस्टर हमने डिस्कस किया, वो नहीं है. चिकन पॉक्स तो डेफिनेटली नहीं है. मोलस्कम कंटेजियसम भी नहीं है. द करेक्ट आंसर हियर इज अ कैपिलरी हिमैंजोमा और एन इन्फेंटाइल हिमैंजोमा. ओके. सो ये जो टेबल है ये बहुत इंपॉर्टेंट है आपको कंसेप्ट समझने के लिए. दो प्रकार के कंडीशंस होते हैं. एक होता है वैस्कुलर ट्यूमर जिसका फोटो हमने देखा, दैट वाज इन्फेंटाइल हिमैंजोमा. और दूसरा होता है वैस्कुलर मैल्फॉर्मेशन जो है पोर्ट वाइन स्टेन. ठीक है. तो वैस्कुलर ट्यूमर में हिस्ट्री क्या होगा? मम्मी पापा बोलेंगे कि बच्चे को एट बर्थ कुछ भी नहीं था, जन्म हुआ तब एकदम ठीक था, लेकिन अराउंड 15 दिन हो गए उसके बाद एक लाल पैच देखा. और ये क्वेश्चन नहीं थे, तो आप बता सकते हो कौन से क्वेश्चन थे पवन? ये क्वेश्चंस मुझे अनअकैडमी ने दिए हैं, तो ये उन्होंने बताया कि ये आए थे. तो अगर आपको लग रहा है कि ये नहीं थे तो नो प्रॉब्लम, आप सुन लो, मे बी आपको बाद में ये यूजफुल हो जाएगा. बट अगर आपको पता है कोई और क्वेश्चन हो तो मुझे बता दीजिएगा. ठीक है. सो vascular tumors also called as infantile hemangioma and vascular malformation also called as a port wine stain. ओके. तो अभी वैस्कुलर ट्यूमर्स में क्या हिस्ट्री होता है कि एट बर्थ कुछ नहीं होता, लेकिन बर्थ के कुछ दिन के बाद देर इज अ रेड पैच विच कंटिन्यूसली इंक्रीजेस इन साइज, enters into the proliferative stage. Okay. And it grows rapidly till 9 months and then it comes a plateau phase, जब वो बढ़ता भी नहीं है, कम भी नहीं होता, और फिर उसके बाद वो कम होते जाता है. ओके. जबकि वैस्कुलर मैल्फॉर्मेशन जैसे पोर्ट वाइन स्टेन में हिस्ट्री ये होगी कि ये जो चीज है ये बर्थ पे थी और फिर उसके बाद वो कभी गई नहीं. ओके. वैस्कुलर ट्यूमर्स विल ब्लांच ऑन प्रेशर व्हाइल वैस्कुलर मैल्फॉर्मेशन विल नॉट ब्लांच ऑन प्रेशर. आपको ये याद रखना है कि इन्फेंटाइल हिमैंजोमा अगर आप ट्रीटमेंट कर रहे हो तो उसका ट्रीटमेंट है प्रोप्रेनोलॉल. अगर इन्फेंटाइल हिमैंजोमा आँख के आजू बाजू में है, अगर नाक के आजू बाजू में है, मुंह के आजू बाजू में है, कान के आजू बाजू में है, जेनाइटल एरिया में है, बड़ा है, ब्लीडिंग हो रही है, अल्सर है, तो वो चीज को आपको ट्रीट करना जरूरी हो जाता है. और इसलिए प्रोप्रेनोलॉल ड्रग ऑफ चॉइस होता है. अगर दूसरी कोई जगह पे है जो कॉस्मेटिकली इंपॉर्टेंट नहीं है, छोटा सा हेमांजोमा है जो तकलीफ नहीं दे रहा है, तो ऐसे केसेस में आप उसको अकेला छोड़ सकते हैं, वो अपने आप भी रिग्रेस हो जाएगा. लेकिन अगर वैस्कुलर मैल्फॉर्मेशन है तो उसका अगर ट्रीटमेंट करना है तो फ्लैश लैम्प पल्स डाई लेजर ही ट्रीटमेंट है. ओके. Remember that when you have a vascular malformation on the face, okay, you should always think of Sturge-Weber syndrome. So when you have portoine stain on the area supplied by the ophthalmic division of the trigeminal cranial nerve, along with that you have focal seizures due to ipsilateral anomaly of the surface of the brain with ipsilateral intraocular vascular malformations presenting with glaucoma, your answer will be your answer will be a Sturge-Weber syndrome. ठीक है. हाँ पवन, आपका आंसर सही है. आई विल बी डिस्कसिंग दैट क्वेश्चन इन द नेक्स्ट क्वेश्चन इज द सेम एज यू टोल्ड मी. यही था ना आपका क्वेश्चन. 29-year-old फीमेल प्रेजेंट्स टू द डर्मेटोलॉजिकल ओपीडी एंड यस यू आर राइट, दीज आर कॉमेडोन्स. ओके. सो पवन आपका आंसर सही है. ठीक है. सो ये ब्लैक हेड्स व्हाइट हेड्स जो बोलते हैं ये कॉमेडोन्स कहते हैं उसको मेडिकल टर्म्स में. व्हेन यू सी अ ब्लैक plug, that is an open comedone, and when you do not see any opening to it, it is a closed comedone or a whitehead. ठीक है. सो एक्ने के बारे में आपको ये पता होना चाहिए दैट इट इज अ प्रॉब्लम ऑफ द sebaceous gland. And remember the pathogenesis of acne. So basically in acne there is first formation of a there is formation of a plug. Okay. And because of the formation of this microcomedone there is accumulation of contents and there is proliferation of the P acnes. सो सी दिस इज कॉमेडोनल फेज ऑफ एक्ने, जहाँ पे आप देख रहे हो कि मल्टीपल ब्लैक हेड्स और व्हाइट हेड्स है. दिस इज ग्रेड 1. फिर उसके बाद आते हैं कि इन एडिशन टू पैप्यूल्स, कॉमेडोन्स, एंड यू ऑल्सो स्टार्ट सीइंग पैप्यूल्स. ओके, सो दैट इज ग्रेड 2 एक्ने. फिर ग्रेड 3 एक्ने में आपको पस्ट्यूल्स भी दिखने लगते हैं. एंड ग्रेड 4 एक्ने में यू हैव नोड्यूलोसिस्टिक लीजन्स. ठीक है, तो ग्रेड 4 एक्ने में देर आर नोड्यूलोसिस्टिक लीजन्स. अच्छा पवन, वो क्वेश्चन मेरे पास नहीं है, बट यस, अगर पेशेंट हैज कमिंग विथ violaceous flat top papular lesions on the hands which were itchy and the same were also present in a reticulate pattern on the buccal mucosa, your answer will be lichen planus. ठीक है, yes पवन, you are right. नाउ ये आपको समझना जरूरी है, द डिफरेंट काइंड्स ऑफ सीवियर एक्ने. तो सीवियर एक्ने में आता है एक्ने कॉन्ग्लोबाटा. तो एक्ने कॉन्ग्लोबाटा पे क्वेश्चन आ सकता है, इसलिए आप ध्यान रखिए. एक्ने कॉन्ग्लोबाटा में क्या होता है दैट देर आर नोड्यूल्स तो होते हैं, सीवियर वेरिएंट ऑफ एक्ने है तो नोड्यूल्स तो होंगे, बट वो नोड्यूल्स के एब्सेस बन जाते हैं, पस अक्यूमुलेट हो जाता है. और ये एब्सेसेस जो है एक दूसरे से कनेक्ट होते हैं, तो उसकी वजह से इंटरकनेक्टिंग साइनसेस फॉर्म्ड हो जाते हैं ड्यू टू फ्यूजन ऑफ दीज एब्सेसेस, एंड इट लीव्स बिहाइंड एक्सटेंसिव स्कारिंग. Multiple grouped comedones are also typical, and treatment is oral isotretinoin with systemic steroids. ठीक है. दूसरी एंटिटी है acne fulminans, which is also called as febrile ulcerative acne. So when you have acne conglobata जैसा पिक्चर, लेकिन in addition वो abscesses के अल्सर्स बन रहे हैं, एंड दूसरा पेशेंट को सिस्टमिक सिम्टम्स है, जैसे फीवर है, आर्थ्राल्जिया है, WBC काउंट पे ल्यूकोसाइटोसिस है, न्यूट्रोफीलिया है. ओके, तो ये सारी चीजें बता दी कि इन्फ्लेमेशन बहुत ज्यादा है. ओके, सो दैट इज सजेस्टिव ऑफ एक्ने फल्मिनांस. तो ऐसे केस में आपको क्या करना है कि पेशेंट को स्टीरॉइड्स देने हैं, आपको वो इन्फ्लेमेशन को कम करना है ताकि स्कारिंग कम हो, और उसके बाद आपको आइसोट्रेटिनोइन अगर चालू है तो उसे बंद कर देना है. स्टीरॉइड्स देने के बाद जब थोड़ा कंट्रोल में आ जाता है कंडीशन, फिर उसके बाद आप आइसोट्रेटिनोइन शुरू कर सकते हो, लेकिन बहुत ही कम डोज में शुरू करना है. एक्ने एक्सकोरी का मतलब ये होता है कि patient has a compulsive picking of acne, and that gives rise to pigmentation. Okay, then there is an entity which is called as body dysmorphic disorder, where some patients with body dysmorphic disorder, they have acne as the prime symptom, and the primary perceived acne is out of proportion of the physical signs. ओके, सो दिस इज कॉन्ग्लोबाटा, एक्ने कॉन्ग्लोबाटा. तो आप देख पा रहे हो कि यहाँ पे देर आर मल्टीपल नोड्यूल्स एंड दीज आर इंटरकनेक्टिंग साइनसेस, and definitely it was going to leave behind a lot of scarring. Okay, this is acne excori, where you see multiple erosions, and you can see that they are all healing with hyperpigmentation. Okay, now treatment of acne. I can understand, Daman, see, even if there are no, we cannot get that same image, right, which was there in the exam. So whatever is possible, a similar looking image is provided. ठीक है, बट द इम्पोर्टेंट हियर इज दैट यू शुड नो द कंसेप्ट वेल. ठीक है, हाउ मच डिफरेंस वी सी इन द एक्चुअल रिजल्ट फ्रॉम द रिकॉल बेस कैलकुलेशन. सो आई थिंक यू कैन कीप अ मार्जिन ऑफ 10%. ओके, सो उतना तो रख सकते हो. ओके, बट डोंट वरी, because see, even here I have not appeared for the exam, so whatever is given to me as recall questions is what I have to discuss. Okay, so exactly वो same question नहीं होगा, but अगर आपको लगता है कि कुछ है मुझे डिस्कस करना है तो मुझे बता दीजिएगा. ठीक है. हाँ, तो ट्रीटमेंट अगर आपका कॉमेडोनल एक्ने है तो टॉपिकल रेटिनॉइड्स यूज कर सकते हैं. अगर ग्रेड 2 एक्ने है तो आपको टॉपिकल एंटीबायोटिक्स कंबाइन करने हैं विथ टॉपिकल रेटिनॉइड्स और टॉपिकल बेंजाइल पेरोक्साइड. अगर पस्टुलर एक्ने है तो आप ओरल एंटीबायोटिक ऐड कर सकते हो. और अगर नोड्यूलर एक्ने है, or if there is acne which is not responding to your conventional treatment with antibiotics, or if the acne is severely scarring, then your treatment of choice will be oral isotretinoin. Oral isotretinoin remember, is a teratogenic drug. You cannot give it to a patient who is planning pregnancy or is likely to be pregnant. The dose is 0.5 milligram per kg per day, and the treatment and the most common side effect of oral isotretinoin is dryness of the lips. ठीक है? Now, the next question: 45-year-old truck driver with history of multiple sex partners comes to the dermatological OPD with the lesions as shown below. So, what is your answer? इसमें क्या आंसर लिखा आपने? 45-year-old truck driver with history of multiple sex partners. Very good, Aman. Yes, your answer is correct. It is secondary syphilis. So basically, these are classical Palmer syphilids. Okay. So in the secondary stage of dissemination, what happens is the Treponema pallidum, it disseminates into the blood. Okay. If you don't treat the primary stage of chancre, then it will go into the blood. Okay. And that will give rise to a rash, condyloma lata. There is generalized lymphadenopathy and mucous membrane patches. Okay, so rash is the most common feature. You can have papules, you can have pustules, you can have plaques, you can have scaly lesions, you can have erythema multiforme like lesions, you can have lichenoid lesions, you can have lesions which are follicular. Okay, so any morphology under the sun can be a possibility in secondary syphilis, but please remember that vesicular lesions and bullous lesions are not seen in the secondary stage of syphilis. Okay, palms and soles are typically involved. Okay, and there is deep dermal tenderness positive, which is called as the Buschke-Ollendorff sign. Okay, also because there is dissemination. Yes, Junaid, there must be a photo. So basically, they are suggesting an STD with an acral area involvement, and that is nothing but secondary syphilis. Okay? Maximum spirochetes can be cultured from the CNS in the stage of primary syphilis, and you can have also systemic involvement. Okay, so in the form of gastritis, hepatitis, glomerulonephritis, proteinuria, acute meningitis. Condyloma lata, they are flat cauliflower-like masses which are seen on the moist skin like the anus, groin, etc. And they are very infectious and they are teeming with spirochetes. These are the typical snail track ulcers, okay, which you see in the oral cavity in patients with secondary syphilis. They are very, very infectious. These are split papules which are seen at the angles of the mouth in patients with secondary syphilis. Now, going on to the next question. 50-year-old presents with to the dermatological OPD with the white patch on the lesions. What is the diagnosis? इसमें क्या लिखा आपने? Is it psoriasis, fungal infection, secondary syphilis or maculopapular drug rash? Yes, so it is psoriasis. So typically here you can see, yes, so that in fact they have given you the clue. If they have mentioned silvery patch, this given you a clue. So as you can see in the picture, it's a well-defined plaque which is erythematous, indurated, and it is covered with silvery micaceous scales. Okay, so silvery micaceous scales are seen in psoriasis. So this is something that you need to remember. So basically, this is what happens in psoriasis. This is the phenomenon of Keebnerization that you see in psoriasis. Keebnerization means appearance of lesions at the sites of trauma in a linear fashion. Okay, this is again because he's wearing the pant, so the pressure comes here. So this is Keebnerization at the site of pressure. Okay, so linear trauma causes lesions to increase in the line of trauma, and that is seen in 25% of the patients, and that is nothing but the Keebner phenomenon. This is the typical plaque of psoriasis vulgaris, where you see the typical silvery micaceous scales. This is guttate psoriasis, where you see multiple raindrop-like lesions. Okay, smaller lesions. The importance of this is that it has a good prognosis, more commonly seen in the pediatric age group, and the treatment is anti-streptococcal antibiotics. This is sebosorasis. Sebosorasis, where you see involvement of the face. You can see the involvement of the retroauricular area. That means psoriasis which is in a seborrheic distribution. This is flexural psoriasis where the scaling is not as apparent. That's because of the friction and the maceration. This is palmoplantar psoriasis. This is nail psoriasis, which is characterized by the presence of pitting. The pitting in psoriasis is typically irregular and deep. And in addition, you can see the presence of onycholysis, means separation of the nail plate from the underlying nail bed. And you can also see the discoloration, yellowish kind of discoloration of the skin. This kind of pitting is called as thimble pitting. Okay, and this is the most pathognomic sign for diagnosis of nail psoriasis, and that is the oil drop sign, also called as the salmon patch. This is onycholysis. Onycholysis means the separation of the nail from the underlying nail bed, and this is subungual hyperkeratosis, both seen in psoriasis. Similar presentation can be seen in onychomycosis, but in onychomycosis there will be tunnel formation. Okay, this is onycholysis, as you can see here. And you should also know everything about pustular psoriasis. Now, pustular psoriasis there are pustules, and these pustules, they coalesce together to form lakes of pus. When this happens in the setting of pregnancy, it is called as impetigo herpetiformis. And impetigo herpetiformis, you cannot give methotrexate, you cannot give acitretin. The treatment of choice will be steroids, and for some reason, if you cannot give steroids, you will give cyclosporin. ठीक है. So I think that's the time that we have. और कोई questions है? Guntur, I am not aware of this question. Dracunculiasis, schistosomiasis, filariasis, वो question क्या था? हमारे पास 2 मिनट और है. आपको और कोई क्वेश्चंस है, कुछ डाउट्स है? आई नो सारे तो इसमें कवर नहीं हो पाएंगे. जो मुझे क्वेश्चंस मिले थे वो मैंने डिस्कस किए. एनीथिंग दैट यू वांट मी टू डिस्कस स्पेसिफिकली? अच्छा, क्वेश्चन ये था कि विच इज डायरेक्टली रिलेटेड टू स्किन. अभी see this I need to know exactly what was the question, because see filariasis में skin manifestations हो सकते हैं. Filariasis में there can be lymphedema as a manifestation, right? So there can be secondary lymphedema due to filariasis. Schistosomiasis causes cercarial dermatitis in skin. Okay, so it's an itchy creeping eruption. Yeah, so spread with direct skin contact is schistosomiasis. Answer is schistosomiasis. अगर क्वेश्चन ये पूछा था कि डायरेक्टली स्प्रेड होता है स्किन से, डायरेक्ट कांटेक्ट विद द स्किन से, तो इट इज सिस्टोसोमियासिस, बिकॉज सिस्टोसोमियासिस में सर्केरियल डर्मेटाइटिस होता है, विच इज अ स्किन इश्यू. ठीक है, क्योंकि फाइलेरियासिस तो मस्किटो से होता है, राइट? हाँ, सो डायरेक्ट इफेक्ट ऑफ द स्किन, देन द आंसर इज शिस्टोसोमियासिस. शिस्टोसोमियासिस स्विमिंग से, जब वो स्किन के डायरेक्ट कांटेक्ट में आता है ऑर्गेनिज्म, उसके वजह से होता है. ठीक है, एनी अदर क्वेश्चंस? ठीक है, ऑल ओके. ठीक है, सो डोंट वरी. आई थिंक everyone who has already appeared for their exam, all the best for the future, and for those who have yet to appear, I think this session will be useful. Okay, so see you in my next YouTube session. Thank you everyone. Bye.